Fascinating talks. I thank our speakers, and I welcome questions from the attendees in the room if you wish, but I will go ahead and, Dr. Ghazi, you have a question? Do you have a mic? Thank you very much. Let's use the mic so the attendees who are online can hear us. One moment, please.
Grateful to you and the speaker, really a fascinating subject. Just a comment that I think osteoporosis is really, I don't think we have an association in Bahrain, I don't know about Saudi Arabia, but it is a subject which is really, I mean the surgeon, they are the one who really dominate the field, and they are not interested in osteoporosis, just the procedure, and that's what we do. And I'm sure it is more prevalent, you know, and I'm sure we could do much more. Regarding the vitamin D, I don't know how prevalent the vitamin D in Saudi Arabia or in other areas, but certainly in Bahrain, I think at least 80%, you know, of the population, they have vitamin D deficiency. And that's reflect on the next subject, which is the parathyroid hormone. I think you probably, if you measure the parathyroid hormone, I'm not sure the parathyroid hormone is the normal, is 30 nanogram per mil. You know, certainly it seems to be more or less depending on the population and the way they measure it, you know. And I think it may contribute to the high parathyroid hormone which you projected. Other thing, you know, I think you have possibly, I don't know, you haven't taken account into parathyroid hypocalciuric hypercalcemia, which really can bring for you a normal PTH, you know, or slightly high PTH with normal or high serum calcium. And that's really congenital, and probably you don't need to do an operation at all for the patient, you know. I think there is many subjects, you know, on both papers, but certainly it's an excellent subject to raise, you know, but certainly we need to follow it by more discussion.
If I can comment on the vitamin D issue and probably also relate to Nasser's excellent presentation. And so yes, vitamin D deficiency is very common in the Gulf area, as we know. It is getting better a lot. I mean, I've been in Saudi Arabia for over 20 years, and I can see the differences between early time when I came and was so interested in the vitamin D deficiency issue. There was a little bit of time where we exaggerated our response to vitamin D deficiency to a certain degree. I think we still exaggerate, but it is real, and it is really affecting maybe the quality of the bone and the issue that Dr. Johani has mentioned. So in that regard, actually I had discussion with Dr. Bilzikian, who had described this entity of Eucalcemic Hyperpara, because I said if we apply the criteria to our patients, because we see high normal to slightly elevated PTH, I would say in 30 to 40% of the population, that means all those patients might have Eucalcemic Hyperpara. Of course, Nasser was very, very careful in dissecting this issue and ruling out and observing before you make such a diagnosis. But still, my theory, and he agreed with this, and of course we have to prove it, that probably the long-standing vitamin D deficiency we have in the population has reflected in the higher PTH value, but you can also question the assays we use. And so therefore, a slightly elevated PTH, I start to ignore, honestly, with a normal calcium, especially if the calcium is below the mid-normal. Yet some of those patients might have a real eucalcemic hyperpara, which may be a milder form of real hyperpara, need to be observed truly before we jump to diagnosis. And I would say be very careful and apply all the points that Dr. Johani has mentioned. I'll let Nasser answer your other part of the question, which is about hypocalcemic.
Thank you very much for your question. Of course, if you find high parathyroid hormone is mildly, as we said in primary hyperparathyroidism, 10 to 15% normal calcium. If you do ionized, you will diagnose them, ionized serum calcium. But it is not easy to do it, okay? The other thing, also put you in the mind, familial hypocalciuric hypocalciuria. if you find patient below the age of 30, if there is family history of hypercalcemia or parathyroid disease, if there is low urinary serum calcium, okay, the calcium creatinine ratio less than 0.01. So in young patient, usually hyperparathyroidism is middle age, is not young age. So if young age, you should suspect the diagnosis something else, either familial hypocalciuric hypercalciuria or multiple endocrine neoplasia, 1 or 2, or familial, some issue. So this is not the age of primary hyperparathyroidism. For me, really, in Saudi Arabia, I assume that the prevalence of vitamin D deficiency, if the female not in supplement, 100%, really. And male maybe 80, but most of the patients now really, if you come to the clinic, they are in supplement. But if you remove the supplement, because all the food not fortified, they are not exposed to the sun, they are covering all the times, okay? Many people, they don't treat, and probably some people they treat if above 20 nanogram per deciliter, even not above 30. But in this definition, to just avoid confusion, better to raise it above 30 nanogram per deciliter.
Of course, the main differential between the Eucalcemic Hyperpara and benign familial hypercalcemia is the calcium is elevated in benign familial hypercalcemia. It will be normal in Eucalcemic hyperpara. The main differential will be with the real hyperpara, hypercalcemic hyperpara.
I will move to several questions that we have listed here. There's a question for Dr. Hussein of how soon after menopause do we start the screening of women? And the other question is about ordering bone turnover markers in the drug holiday.
Yeah, very good. So I skipped those slides, but it is an important question. Most of the societies worldwide has approved screening for age 65 and above. Now, we can argue whether we should adopt this or say 60 in our population. I remember that the Saudi Society for Osteoporosis argued for 55 at one point, and I was pushing them to go to 60 minimum because we overdo it, and there's no reason to start very early. But you can start earlier if there's an indication, high fracs. So now with the fracs, I think it's easier to answer this question. Do your fracs without BMD, and if the fracs risk is a bit on the high side, there is history of fracture, loss of height, many risk factors, then you can do BMD before age 65 or 60 or whatever. And the other part was?
Bone turnover markers.
Yeah, so bone turnover marker can be used normally to guide you in the treatment. So if you decide this patient has osteoporosis and will embark on treatment, then a baseline bone marker would be helpful because you can follow this in a few months to know that the suppression of the bone marker, which means a response to the anti-resorptive therapy or increase in bone formation marker if you use anabolic, correlate actually with the response to therapy. So it may be a good tool, although it's not widely used clinically.
And then we have a question for Dr. Nasser about combination. Is there a role for combining cinacalcet with an anti-resorptive agent in women with, or people with normal calcemic hyperpara?
We know that more experience, of course, with hypercalcemic primary hyperparathyroidism, that if the patient not fit for surgery or refuse surgery and has osteoporosis, we combine cinacalcet. Cinacalcet only treat high calcium level. So will decrease the symptom like fatigue, thirst, polyuria. Will not treat renal stone, will not treat osteoporosis. So if already the patient also has osteoporosis and refuse surgery, okay, because we know that osteoporosis is indication for surgery. We can start the bisphosphonate or denosumab, either of them, because it will not affect, as we said. So only affect is anti-resorptive.
And the other question is, and I'm mindful of time, so this will be the last question, unless the audience here have some. So Sglt2 are being used more commonly. Is the increase here in PTH mediated by its diuretic effect, its calciuric effect, or a direct effect on PTH? Do we know?
Is that diuretic?
No, the Sglt2 inhibitors.
Exact mechanism is not known, but what they hypothesize that we have selective glucose transporter 2 mainly in the proximal tubule in the kidney. Also we have glucose receptor also, okay, selective glucose receptor in the intestine.
Yes.
Also, this represents 10% inhibit glucose absorption in the intestine. If you inhibit it in the intestine, will increase distal delivery of the glucose to the intestine. The bacteria there in the intestine will cause fermentation, okay, of the glucose. This will make the media acidic. And acidity by itself increase reabsorption of the calcium. So the mechanism or hypothesis is that there is effect of selective glucose transporter inhibitors in the intestinal receptor by indirect way increase absorption of the calcium by intestine. This is the reason.
The mic, if we can pass it to our guest there, and that would be our last question.
Thank you very much.
But exactly, yani, is not known. But we should consider drugs. Really, drugs very common. Many patients, when they do parathyroid hormone, they are already in denosumab, they are already in bisphosphonate when you evaluate them.
Thanks for both speakers. Excellent presentation. My question to Dr. Raif, what do you think about follow-up of osteoporosis in those patients who move from a hospital to another, and then they will go and they will say the T-score increased by 0.5, decreased by 0.5, different machine, different maybe technician, and then they follow T-score rather than BMD. What is your thought in that regard?
Right. So this is a common problem, really, and the guideline always insists that whenever possible, the patient should have his follow-up in the same place, even same machine, because those bone densitometries are not extremely comparable to each other. And if you change the type of the machine, it's even worse. But I've noticed it all the time. People come from outside. I cannot take that as, you know, either they have to go back to the same place, and then therefore I'll take the changes there, or I have to start from another baseline. So it is really difficult to compare two different institutes, two different machines.
Just a comment and questions to you, the presenters and the cardiologist, Dr. Isir, with you. What's the view on using the K2 in osteoporosis, possibly the cardiac K2?
K2? Yeah. Oh, vitamin K. I heard little about it. I haven't seen much evidence, but I haven't looked in the data recently. So if you have something, tell us.
Evidence.
Yeah, I heard it from patients mostly, but I haven't seen much.
K has pathways to work on. I don't think it's linked to the. Sorry. Vitamin K is having different pathways in terms of the mechanism. As far as I know, I haven't heard the literature is that there is a use of such things in osteoporosis.
So,
MK7, K2, vitamin K, which has been advocated for calcium scoring. It's one.
Yeah, but
know,
we need.
Popular sense.
We need that.
They use it, you know, but the proof for it still.
no proof.
It's a new wave of things. The danger is when we take theoretical knowledge, even when we took vitamin D, of course, vitamin D receptors work on lymphocyte, work on cancer cells, and we start to say, okay, to prevent type 1 diabetes, prevent cancer, etc. None of this was proven. The only effect of vitamin D that was proven was on bone. That doesn't say it doesn't work, but you cannot prove it clinically. So the use of the treatment, and this is vitamin D. For vitamin K, it's another wave, I think, and we have to see the evidence.
We need a controlled randomized study to support this.
So allow me, in the interest of time, to thank our speakers. I personally still have lots of questions, so if you don't mind, I will keep you and ask you. And Dr. sent us a message that we are expected to be in Hall A for the satellite session. So a big thank you to our speakers. It was a wonderful session.